All right, so now you know how to diagnose and recognize and treat a capsulitis, but a lot of you that are on this webinar tonight are doing a lot with dental sleep medicine. You're treating with oral appliance therapy, and you may be thinking, how in the heck, Jameson, could a capsulitis occur when somebody has an oral appliance in their mouth, for crying out loud? Because we know that with this appliance in their mouth, we're taking that condyle down and forward, dramatically down and forward. So there's no way that we would be pushing on the retrodiscal tissue, is there? Now, you may say, well, maybe I'm stretching it, and that's a possibility, but I think that's relatively rare. Rarely are we going to be taking the condyle so far forward as to cause a stretching of the retrodiscal tissue, because people yawn, people open their mouth way wider than we would. So just opening your mouth wide for a yawn is going to take the condyle much farther than we would with an oral appliance, unless you are really taking people far forward, which normally you don't need to do. So what is the cause of a capsulitis when people are using an oral appliance for sleep apnea? Well, I think there's several things that could cause this, but I want to talk about one in particular that is very important and can cause this to happen quite often if patients are not educated in the right way. And that is the patient clenching, and not just clenching, but clenching in the morning, trying to get their teeth back together. Okay? So various people teach various things on getting people's bite back, and we're going to talk here about the morning repositioner. And depending on what you use for the patient to help get their teeth back, there could be a problem with the patient actually doing this too aggressively and causing a capsulitis. So we want to avoid that. So here's kind of the rules of thumb here. You want your patient to leave their oral appliance for sleep apnea out for at least 10 to 15 minutes before using their morning repositioner. Regardless of what type of morning repositioner you're using, I like to have the patient leave the appliance out for at least 10 to 15 minutes, longer is fine, before they start to try to get their jaw back. Now, if the patient's having joint pain in the morning, so you've diagnosed a capsulitis, then you might consider actually having the patient leave half the appliance in for that first 10 to 15 minutes. Now, why is that? So again, if they have the capsulitis, so in the morning they say, oh yeah, I take the appliance out, I can barely get my teeth together, it really hurts. They've got that pressure, they've got that inflammation in the joint. So wearing half of the appliance would be kind of like that aqualizer effect. It would put a space between the joint. Now, you know that you can't do that with all appliances. A herps, that'd be a big hassle. They'd have to take the bars off every day. But there are some appliances that lend themselves to this, where it'd be easy for the patient to wear just half of the appliance, a dorsal fin appliance, for example, or an EMA, for example. There's a lot of appliances where wearing half the appliance would be okay. Now, on the morning repositioner, I've gone through a lot of different morning repositioners over the years, and I'd like to share with you what I think is the best way to do a morning repositioner. And this is the work of several of my friends, and we've changed it just a little bit to make it very, very predictable. So the armamentarium for making a morning repositioner that's going to be truly effective is Thermacryl Plus, and then we will have not just articulating paper, but shim stock. I'll show you why we're going to use that shim stock right here. So what we want to do is, our goal is to make an anterior jig that will bring the patient back into their habitual occlusion. Now, prior to making this morning repositioner, we're going to check that they have posterior occlusion. That's what the shim stock's for. So I encourage you to check the patient's posterior occlusion, to go through all of the teeth and make sure that they actually have contact. Because if they don't have contact, then it's going to be really tough when they come in and say, hey, I think my bite's changed, and you don't know what their bite was in the first place. So this has made a big difference for me, because our patients don't know if their back teeth touch. When you ask, do your teeth touch and stuff like that, they say they do, but they don't know. It's kind of like when I ask dentists about popping and clicking. And I'll ask a room full of dentists if anybody has clicking, and dentists will raise their hand that they do, and I go around and it's actually just their condyle going over the articular eminence. They don't have a disc displacement at all. So if we as dentists don't even understand this stuff, how in the heck can our patients understand it? So just check. Have them bite on the shim stock, see if you get pull. If you don't have contact, then note it, okay? Now, we're going to keep that shim stock handy though, because as we take this material, this Thermacryl Plus, stick it on the lower front teeth. We basically make a little Jolly Rancher there, stick it on the lower front teeth, and then we have the patient bite down on their back teeth. Super critical that they bite on their back teeth. And as you know, a lot of times you say, hey, bite down, and the patient bites on their front teeth. If they bite on their front teeth, you just take it out, rewarm it up, and try again, getting them to bite on their back teeth. Now, I used to just do it this way, and now we've added checking with the shim stock, checking to make sure that that patient is truly on their back teeth. Because before, I just took it for granted that, yeah, well, they must be biting on their back teeth. It looks like they're biting on their back teeth, and they weren't. So we check that now. Now, the cool thing about this technique is you know that they're hitting on their back teeth. That proprioception of you hitting on your back teeth is super important. You also have a record of their lower front teeth, where they were. You have a record of their upper front teeth, where they were. In other words, if everything seats, if everything is going into place, then nothing has changed, or it's all changed as a unit, okay? But this is a fabulous way to make a morning repositioner. Now, if you use tap appliances, you may have a whole bunch of these AM aligner discs laying around, and you could also do the same technique, and this is a technique called the cowboy hat that my staff developed, where we take these AM aligners and cut them into thirds. And then you do the same thing as we did with the thermoplastic beads, but just with that AM aligner arch cut into 3 pieces. So you heat it up, stick it on the lower teeth, bite down. And the cowboy hat part is you push up the corners, you push down the center, push up the sides, and it ends up looking like a cowboy hat, kind of an inverted cowboy hat there. And the same thing, once we get done, we have a record of the lower teeth, the upper teeth. We know that the posterior teeth are in occlusion because we checked with the shim stock. This is a great way to do your morning repositioners. Now again, with any morning repositioner, make sure that you remember that you want that patient to leave their appliance out for at least 10 to 15 minutes before they're using the morning repositioner. And when they use the morning repositioner, you want them to not bite on it really hard, okay? Tell them, I don't want you putting this in and biting as hard as you can. Put it in and gently squeeze, gently squeeze. It may take you a few minutes. You may do this on your way to work. You know, just gently, gently, gently until you feel your back teeth coming together. That will allow the fluid that has come into the joint overnight because of that forward position. Remember, there's no space in the body. There's potential spaces. And as we bring that condyle forward, we're going to fill that capsule. We're going to draw in some fluid. That's not really inflammation. It's just fluid. But what could happen is if that person puts in their morning repositioner immediately, bites on it really hard, then they could squeeze all that fluid. It's got nowhere to go because there's a capsule there. So hydraulic force, and that could injure the retrodiscal tissues and cause a capsulitis. So I hope that makes a lot of sense for you.